Welcome to the Drip Podcast, hosted by myself, Angela Craig. I am an advanced practice nurse, a clinical nurse specialist, and a senior medical manager with medical affairs at Baxter. DRIP standing for D, define, R, research, I, innovate, and P, practice. It embodies a patient centered, evidence based approach for cutting edge medical science. Our mission is to foster scientific discussions with the brightest minds in emergency and critical care, with a never ending ambition to save and sustain lives. Join us as we navigate through topics like fluid management, fluid choice, and shock resuscitation. Today's guest has waived speaker fees from Baxter and has graciously offered to join this podcast voluntarily.
Hello and welcome to the Drip Podcast, hosted by Angela Craig. Our guest today is an Assistant Dean of Advanced Learning and Simulation at LSU Health Science Center, creating educational and training programs to advance the next generation of healthcare providers, developing a standardized patient project that focuses on challenging communications, and broadening industry partnerships in medical education that strengthens the LSU Health New Orleans mission. He completed medical school at Louisiana State Health Science Center. He completed an internship in internal medicine at LSU Health Science Center Department of Medicine and Residency and was the chief residency in emergency medicine at LSU Health Science Center Charity Hospital. Please welcome Dr. Peter DeBlieux.
Welcome, everyone, to our podcast with Dr. W. My name is Angela Craig, and I am a senior manager with medical affairs here at Baxter Medical. And I am so excited to have Dr. W with us today talking about fluid creep. Dr. W, we're so happy to have you with us today. Can you give us just a little bit of information about yourself, who you are, and since obviously we can't tell by your background where you're from, just a little bit about you?
Certainly. So thank you again, Angela, for inviting me on the podcast. My training's both in emergency medicine and pulmonary critical care medicine, and I trained in both of those at LSU in New Orleans at Charity Hospital. And I've been practicing for over 37 years and also involved in academics, where I'm now with LSU as the Assistant Dean of Advanced Learning and Simulation in New Orleans.
Awesome. That's amazing. Well, you look really great. I think if I lived in LSU, if I lived in New Orleans, I think I would be way overweight from all the beignets I would eat. I was recently there and definitely enjoyed a few of those, probably too many. But I am super excited today to really just pick your brain about some fluid management concepts, and you're well versed in this. And really want to start with the concept of fluid creep. You and I spoke briefly recently, and you talked about this, and I really like that just to be able to kind of expound on fluid creep and talk about our lack of hospital reconciliation of fluids and how fluid creep can actually be detrimental to our patients.
Yeah, so let's first talk about what do we mean when we say fluid creep? And this is the administration of fluid in an unintentional manner in a patient who might be in a shock condition. In this case, we'll really emphasize, for the purposes of our audience, the patient who's in septic shock, if you will. And so, oftentimes, over 60% of the time, those patients are transported by EMS. And some of those EMS runs can take a long period of time. And if those patients are hypotensive and tachycardic, they're going to receive a fluid bolus. And we know that that fluid bolus could be Ringer's lactate, that fluid bolus could be normal saline, and we don't know how much is going in. And there's rarely a great reconciliation between the EMS team and the emergency department team. So now that patient's in the emergency department and may have received no fluids, but the chances are, if they were in septic shock, hypotensive, and tachycardic, they received maybe 500 cc's, a liter, in some cases even 2 liters fluid bolus to address their frank hypotension and tachycardia. it's far more likely that they'll receive crystalloid fluid boluses than vasopressors from an EMS crew. So the patient now presents to our emergency department. They continue to be hypotensive, they continue to be tachycardic, and we're probably going to start with a SEP1 CMS recommendation of 30 cc's per kilogram, not reconciling whatever fluids the paramedics gave them. And that's through no fault of the paramedics, through no fault of the ED. We're just simply following a protocol. And chances are that protocol is going to use 30 cc's per kilogram. And more often than not, they're going to use total body weight. Not an ideal body weight, but a total body weight. So if we then talk about numbers and say, who's presenting to our emergency departments and what do those patients look like? Almost universally, 60 to 70% of the time, those patients will have elevated BMI. And so we'll give a 30 cc per kilo bolus. We'll also give them, if we're thinking this is septic shock, they're going to receive an antibiotic. And chances are they're going to receive more than one antibiotic, and that's probably going to look like Zosyn or cefepime and vancomycin. And so they're going to receive a fluid bolus. And if our patient that wasn't responsive to EMS is now not responsive to our fluid boluses, chances are we'll give even more fluid or start them on a vasopressor. If we start them on a vasopressor, that's going to come with its own fluid. Those antibiotics will come with their own fluid. And then if the patient continues to be in a shock state, there's a strong likelihood that that patient will need invasive mechanical ventilation. So they'll need to be intubated. And many people will be very cautious intubating somebody in a shock condition, and they may receive more fluid boluses. We'll then intubate them and place them on a sedative. And that sedative is going to come in fluid. And then the patient's going to be sick enough that they're going to need to be admitted to the ICU. That patient's going to be transported to the ICU should there be a bed available. And if the patient is found to be hypotensive in that ICU, the chances are they'll receive yet another fluid bolus. And so rarely can it happen? Yes, but does it happen? Rarely. There's reconciliation between the fluid of the EMS group and the emergency department, and rarely still a reconciliation between the fluid given in the emergency department, and again, all of those fluids, the boluses, as well as the drips that are associated with either sedatives or antibiotics, or reconciled to the ICU, and then making sure that that patient's not receiving a fluid maintenance dose of crystalloid as well. So that's a lot of fluid in a very brief period of time when we know that there's increased mortality associated with excess fluids and excess crystalloids.
So true. And, I guess in my mind, I think it's the year 2025. Shouldn't we be able to figure this out? Like, surely there should be some magic something out there that would help us to get this right.
You would hope that the electronic health record that EMS uses would flag to the ED's health record, which would flag to the ICU's health record, which would denote that the patient was an elevated BMI and should be receiving no more than 30 cc's per kilo, ideal body weight, not total body weight.
Right. Right. Well, we definitely need to do better. I know at my institution, sometimes there's a 24-hour lag potentially before we get the official reports from the EMS into our EMR system. And that, in my mind, is really unacceptable. So then there's a heavy reliance on that communication factor verbally, but then it takes verbally and then having to get it in manually into the EMR, and that's a whole nother challenge, right? And extra steps that people many times forget, not because, like you said, it's not that they're not good practitioners. It's just they're busy. They're trying to focus on the patient, and then sometimes we just miss that. Then.
Yes, and oftentimes these septic shock patients have bumps in their creatinine, and with elevated creatinine tends to be our knee-jerk response to give a fluid challenge or a fluid bolus on top of the fluid that they've already received. And there is some data, again, for elevated BMI published in 2018 that shows increased mortality if you use total body weight versus ideal. There is some data that shows that if you get more than 5 liters of crystalloid in the initial 24 hours, that there's a trend towards increased mortality, and that there's some data from the FRESH group, that looked at excess crystalloids, again, associated with increased mortality. So these are legit problems that we're facing that because we're not in a rush to satisfy SEP1 CMS measures, but we tend to be a little bit more cookie book, right, than we should be. Little recipe laden.
Yeah, and I hear you, and I think one of the things that I'm seeing in the literature more is there's such a need for more personalized care and being more specific for our patients. So, yes, we have a set of guidelines that are meant to guide us, right? But at the same time, you're going to have caveats from that of patients who maybe are not fluid responsive, who cannot accept, their heart cannot accept that volume to help for forward flow to improve perfusion, right? So, how do you feel about let's just throw this out there. What if we did fluid responsive tests in the emergency department?
So I think that that's half of the question, not the full question, but I like the question a lot. And so we challenge our residents and our practitioners to use a focus exam. And what are they looking at? They're looking at the lungs for looking at B lines or evidence of fluid overload. They're looking at the left ventricle to look to see what does a squeeze look like for that left ventricle? Is it vigorous or is it really wimpy? Does it show maybe a poor ejection fraction? We also look at the inferior vena cava for looking for collapsibility. Um, but beyond that, we should be doing things like a passive leg raise. When we're administering that fluid bolus, we would look for either change in stroke volume and measure that, or stroke volume index, and trying to see whether that mimic passive leg raise actually improves forward flow and output for our patients. And you can use that with ultrasound. You can also use some technology looking at bioreactance or bioimpedance for some cases if you have that technology. It does require certain expertise in order to interpret that data.
Yeah, I agree. And, I am a firm believer in, sometimes people have these technologies like in the closets where they've quit using them. And I say, bring them out. We need to be looking at stroke volume guided fluid management. And you really brought up a good point that I think there's real synergy in like the POCUS assessments or looking at ultrasound for that wet dry assessment and then determining, hey, are they fluid responsive as well? Because let's face it, you can have a patient who looks like they're dry, but their heart is not responsive to the fluid. So maybe we need to tone them up first. But you bring up some really great points. What are your thoughts about having something like the combination of technologies accepted more widely in institutions?
Well, I think that there, depending on the complexity of the patient, you might need more technology, right? And whether that's, bioimpedance, bioreactance with ultrasound, whether it's looking at ultrasound, looking at the latest and greatest analysis, which looks to be VEXUS, venous excess in ultrasound. So looking at not just the left heart, not just the IVC, but looking at the hepatic vein as well to kind of get a mirror of see what's going on with Doppler flows of the gut as well as Doppler flows of the kidney and interpreting those. And I think that that's the latest and greatest moves for fluid analysis in critical care.
So, along those same concepts, Dr. W, how do you feel about maybe starting fluids and pressors at the same time?
Yeah, that's been a little controversial in the literature, showing that there's been no mortality benefit. But I would tell you that the current practice habit in critical care is not to allow your patient to be abjectly hypotensive, um, awaiting a fluid bolus to take effect. That many practitioners in the emergency department, in the ICU, and in EMS are administering vasopressors, whether they be push dose pressors or whether they be levofed in the setting of septic shock and titrating that simultaneous to administration of fluid boluses. I think where we really pushed forward with that is in looking at our patients who required um, intubation and airway protection. And in those cases, many of those patients were receiving push dose pressors at the same time as fluid boluses because the fear was the institution of positive pressure ventilation was going to suppress venous return and create a setting where the patient was going to have a worsening of their hypotension. We know that predictive models of shock index, where your heart rate is higher than your systolic blood pressure, is a predictor for patients who are going to have trouble and worsening shock with positive pressure ventilation and intubation. And in those cases, when we call those physiologically distressed airways, right? Not anatomic, but physiologic distress. Those patients benefit from pressors and fluids prior to the institution of positive pressure ventilation.
Yeah. Well, I think once again, it goes back to there's not one way of doing it. And we need to do what's best for the patient with the best information that we have about the patient, right? And if they're hypotensive for periods of time, what that does long term, right?
Oh, sure. It can create other injuries, steal phenomenons, extend MIs, create stroke, have further kidney injury, and then gut injury. So we want to avoid that. But I think this concept of push dose pressors. I'm a bigger fan if I know the patient's coming in and is hypotensive and is either cardiac arrest or septic shock. I'll ask for levofed drip awaiting the patient's arrival if they're not already on it. That's not expensive care medicine. It costs about $10 to create that drip. And so it prevents that delay. Um, so I'm a bigger fan of levofed titrating drips than I am push dose pressors. But if you don't have the pressor and you do have push dose, absolutely use it.
Yeah, and I think that a lot of research has been done recently that says, with, of course, appropriate safety nets, that we can do that. We can do that peripherally. So I think there's really no reason for someone to sit hypotensive for long periods of time. There's just
Certainly
no acceptance of that.
Right, certainly not waiting for central venous access. Peripheral access, looking at 18 and sometimes excess of 18 hours with great safety as long as we're monitoring the IV site.
Yeah. And I think if we just kind of get that whole picture, sometimes we get focused or siloed in different areas, but that whole picture to really help us make the best decisions. And like we talked about, for that personalization of care for each patient, for sure. It really is. So, as you, so let me just ask you a personal question. So, what keeps you excited about medicine?
So, what keeps me excited about medicine are it's ever changing, right? And this concept of critical care has a number of different voices in it, whether those voices be from anesthesia, whether they be from medicine, whether they be from surgery, whether they be from emergency medicine. I think that that keeps everything fresh, understanding other people's perspective and what their approach to resuscitation looks like, understanding that not everybody's right and not everybody's wrong. And so we need to be flexible and understand different perspectives in providing care for our patients.
Yeah, I couldn't agree more. Couldn't agree more. Well, what do you read these days? What do you feel like? Is there any good reading out there that you would like to suggest to us?
I think there's a great article that summarizes Vexus and applications, and it's titled Venous Excess Ultrasound, a mini review and practical guide for its application in critically ill patients. It's published in the World Journal of Critical Care Medicine, and it's June of this year, 2025. Um, four, volume 14, 2. And the authors are Chin, Nye, and C. And so I would look at that article in particular, and I think that that's of great value.
That's amazing. That's great. Thank you for that. Well, so as people are listening to this podcast and as they see you on the screen or hear your voice, and they may say, "Man, I would love to reach out to Dr. W." And where how could someone like that reach you?
So for critical care, we do a critical care podcast for critical care perspectives in emergency medicine. And that's, you can just simply Google that. Likewise, you can email me at pdebli@lsuhsc.edu.
Awesome. Well, we thank you so much for your time today. And like I said, I know you're a busy man. I want to thank you for your time. And we're so glad that you joined us. Thank you.
My pleasure, Angela. Thank you.
As we conclude today's episode, I remind our esteemed medical colleagues that the opinions expressed herein are solely intended for professional discussion and should not be construed as medical advice. We encourage all listeners to consult their own healthcare providers for personalized medical guidance.